So today we are going to discuss problems of sensing, oversensing, undersensing in Boston Scientific defibrillators. Right? Okay. So Planche, what do you think?
So this is biventricular ICD.
Yes.
And we can see at the end of the tracing a very fast cycles, both seen on the atrium and the right ventricular channel and the shock channel also.
Yes. See. What do you think?
Definitely looks like oversensing, probably external interference or something like that.
Yes, not the problem of lead dysfunction. You agree it's on the three channels.
Yes. Yep.
Most of the time, the amplitude is the highest. You see, the signals are clipped here. You see, because of the saturation of the amplifiers here, very large signals, and they are the amplitude most of the time is the more important, and the shock channel much more than the RV and atrial channel. What do you think it is?
Probably external noise.
Yes, but which one? Which kind of noise? So this is recorded at the time of implantation, in fact.
Okay, this is an electro cutter.
Yes, electrical scalpel. Okay.
Yeah.
During the surgery, as you see here, no therapy is delivered. Tachy is not programmed to monitor plus therapy. What has been recorded is monitor only. And that's why you will record the tracing, but without possibility of delivering any therapy. Okay, so yep. The diagnosis is really easy when you know that this happened during the surgery. Sometimes you receive this kind of tracing with remote monitoring, and you don't know that the patient was having a surgery at this time. So once you have discussed with the patients, the diagnosis is really easy. Okay, so really polymorphic, very fast on the three channels, and maximal amplitude most of the time on the shock channel. Okay. Second tracing. What do you think here?
Again, biventricular ICD. So we don't see much at the beginning of the tracing.
Mm-hmm. This part is quite similar to what we have seen just before. Okay?
Yeah.
Large amplitude signals, saturation of the amplifiers on the three channels.
Yeah.
What is here? What happens here? It's something like a flat signal.
Yeah.
Listen, without anything. What kind of surgery could it be? It's also an electrical scalpel.
Okay, so maybe the patient, well, I'm not sure. It's inhibited during the surgery, or
no. This is cardiac surgery. You know,
okay.
During cardioplegia.
Yeah.
You see, a typical cardiac surgery. So if you in your center you have a cardiac surgeon or cardiac surgery, just that you know this kind of tracing is very classical. If you do not deprogram completely the ICD, you just stop the therapy, but still program it on a monitor. You will see this kind during the surgery and during the cardioplegia. There are different times during the cardiac surgery. The first one is this, the cardioplegia. So you will see the flat tracing, and then the use of the electrical scalpel. Okay, so I know that these tracing are coming from a single center where they program a monitor, or sometimes they do not deprogram at all the ICDs during the surgery, so monitor plus therapy. And so when I have a look to all their tracings, I could see many of these kind of tracings, so very flat, during cardiac surgery, and then the use of the electrical scalpel. In the same center, now you see a shock is delivered. What do you think here?
Well, again, it's oversensing.
Yes, still the same kind of oversensing. And then
this
see,
looks more like VF after.
here the patient is paced.
Yeah.
Probably electrical scalpel. It's also at the time of surgery. Very fast signals and inhibition of pacing, quite long cycle. And then the onset of something here. What do you think?
Well, this looks more like VF.
A real VF.
Yeah.
Yes, very fast and polymorphic signals, anarchic signals. In terms of counters, always the same. 1, 2, 3, 4, 5, 6, 7, 8 out of 10 at this time. So V episodes, quite short duration, 2.5 seconds. V detect at the end of the duration, and then charge of the capacitors, and the shock is delivered at the end of the charge. You still have always have 6 out of 10 at the end of the charge. 135 blanking milliseconds. The next cycle will not be analyzed. It will be ignored, and then you have 2 fast cycles out of 3. So the shock is delivered on seconds. Okay, but what time of the surgery is it, according to you?
Well, this is probably the end of the surgery.
Yeah, this is the reperfusion.
Yeah.
As I said, I had a look to all the tracing from these centers where there is cardiac surgery, and sometimes they do not deprogram the ICD when the patient undergoes surgery. So you can see quite a low number of this tracing. Most of the time during cardiac surgery, you see first this, meaning this one. During cardioplegia, flat tracings, and then use of the electrical scalpel. And then at the time of the reperfusion, I don't know if it's in use, if it is in use because of the problem of oversensing. You see long and short cycle. I think this is typical VF induced by the reperfusion at the end of the surgery. You understand? And,
yes.
And I have seen many of these tracings with at the end the ICD which delivers an electrical shock. Really, I think it's a better idea to deprogram the ICD for the surgery and use external shocks in case of VF, because you will drain the battery, and I don't think it's useful to see this kind of tracing. Okay?
Yes.
But at least you need to know this typical aspect, this one for the last time. Flaps, and then this, because sometimes you receive this tracing with remote monitoring and you don't know that the patient had a cardiac surgery, and it's really typical. Okay. What do you think on this one? So you see now burst, ramp, shock for an episode of VT. What do you think? So still triple chamber ICD,
yeah,
atrial signals, right ventricular signals, bipolar, and then the shock.
Yeah, there's some kind of double counting on the bipolar ventricular channel.
Yep.
And it's looks like P-wave double counting.
Yeah.
No?
It may look like it, but it's not. If you look at more precisely. On this one, you could have a doubt. You see here this signal, and you could say maybe this one is oversense. Okay. But if you look on the next cycle, you see there is a first signal and a second. So on the right ventricular channel, it's quite organized. These signals, this one, 1, 2, 1, 2, 1, 2, with a fix. You see, these intervals are fixed, and these also are fixed. Okay, and alternance between 2 morphologies. Okay, so one of the possibility would be T-wave oversensing. It would be P-wave oversensing, but now, if you have a look to the atrial signals, What do you see? So if you look at the real atrial signals, the P wave, you agree it would be this one?
Yeah.
So now if you look carefully, see that this is what you see on the right ventricular channel is not perfectly, you understand?
Yeah.
This one, it's not timed, okay? There
Yeah.
is no alignment here. So I don't think that there is oversensing on this channel of this signal, okay?
Yeah.
So if this is the P wave, what is this one? You see the small one?
Yeah.
And now if you have a look, you see that at the same time here, you have the same signal here, okay? On the atrial and the ventricular channel. It's exactly at the same time, and it's really reproducible, okay? What do you think?
I don't know.
This is an
I
artifact.
think it's think about the largest supplier of your pacemaker implantations.
Yes. The one you always thank on Monday and on
The
Friday.
TAVI guys.
The TAVI guys. Yes, exactly. What do you think it could be? You know, for implantation of TAVI, at what a certain time during the implantation, you will do rapid pacing.
Yeah.
You see external rapid pacing. So
Mm.
you see, you paste, and then you sense. You pace, you capture, and the defibrillator will both sense the artifact of pacing and the depolarization after. You understand?
Yeah.
But on the right atrial channel, you will only see the pacing stimulus and not the depolarization of the ventricle. Okay, because you have placed a lead inside the right ventricle. Okay. So this is quite classical, and you can see many of these tracing, in fact. Okay. Now, if you look at the markers, VT, VF, VT, VF, VT, VF. So after 8 out of 10, you see, you will have the marker V episode. For the VT zone, you will never fulfill the VF 8 out of 10, okay, because you only have 50% of VF signals. Understand that?
Yes.
Clear? Yep. So just remember this one. First of all, if you implant a TAVI in a patient with defibrillator, you should also, as the same, deprogram, monitor, and therapy. Because in this patient, I'm a bit surprised that the physician have not seen this, because after a certain time, at the end of the duration, the initial duration for the VT zone, an ATP is delivered. Okay, then reconfirmation. Redetection 1, 2, 3, 4, 5, 6, 7, 8. So 8 out of 10, 1 second duration, and then a new therapy. And luckily, most of the time, the run of pacing are in between 10 to 30 seconds. You see, you pace rapidly to decrease the cardiac output to facilitate the implantation of the valve. Okay. Luckily, here you see that when you arrive to the time of the shock, you see, chart of the capacitors, luckily you stop pacing. I don't think the physician has seen everything, because you cannot know that you will charge the capacitor at this time. But when you charge the capacitor, you end pacing, and therefore at the end of the charge, you see the way it works, the first signal is ignored, and then 1, 2 out of 3 are slow, so the shock is diverted. Okay, the charge is diverted. Okay, that's clear?
Yes.
Okay for you? So this kind of tracing, it's easier when you have an atrial signal, because you can see now. Because if there was no atrial signals, maybe I could have thought this is the atrium, this is the ventricle, this is the atrium, as you said initially. You see?
Yeah.
But for if we did not have this information, for example, I could say, okay, this is the atrium, this is the ventricle, this is the atrium, this is the ventricle. Okay, but most of the time when you oversense the atrium, it's not as sharp. You see?
Okay.
Very sharp here. So that could be a bit different. Okay, clear?
Yeah. Interesting tracing.
So remember this kind of tracing, because I don't say we see many of this, but we see some of this tracing, and you need to think about, maybe this is rapid pacing during a TAVI implantation. Okay.
Yeah.
Good.
Perfect.
Case of patients here, what do you think?
So there's an alert for high impedance on the ventricular lead.
Yes, we're going to redo a course, one of the Monday. It's going to be all dedicated to the problem of the leads. So I'm going to be very short here. What you see here, it's a problem of impedance, high impedance. And when you look at the memory of the device, sorry, you see the value.
Yeah.
It's completely stable, and one time you increase. So you see both abnormal values, more than 2000, and rapid change in this value. So these are two signs of dysfunction, but also non-sustained ventricular episode, many on, and before there was no. So you see, in a very short amount of time, you see many episodes on non-sustained ventricular episodes. And when you look at the tracing, this non-sustained ventricular episodes, you see this. What do you think?
Probably a lead fracture.
Probably, yeah, a lead fracture, because of the high impedance and because of the, once more, high amplitude of the signals with some duration of the amplifiers. Okay, so this is quite classical for a lead dysfunction and a lead fracture. Once more, we'll spend much more time in the future to discuss about that. Up. What do you think here?
Okay, so this is P-wave double counting, this one.
Not double counting, P-wave oversensing. Double
sorry, oversensing.
We use it for the R wave, okay?
Yeah.
So, yes, I agree. So the actual signals, so it's a sinus rhythm here.
Yeah.
It's probably, you see, atrium to ventricle, one-on-one conduction. And if you look on the counters and the markers, you see here, this signals oversensing, one signal, and then the next one is for sure is short. What is the duration of the ventricular blanking post sensing in Boston? You know that? Once you have sensed a signal, during which duration you cannot sense anymore in the right ventricle?
135 milliseconds.
Yes, exactly. It's 135. It's not, you cannot modify it here. Okay, that's something which is fixed and you cannot modify. So no possible, you will never see signals faster than 135. That's impossible in the right ventricle. Okay.
Okay.
This is the limit for the detection. But here clearly you see oversensing of the atrial activity. Are you surprised that it happens in Boston Scientific device?
Assuming it's Boston lead also? No.
It is.
Yeah, no, because of the integrated bipolar configuration.
Yes, if you have a look to any book, textbook on ICDs and interrogation of ICDs, most of the time, P-wave oversensing is illustrated with a case of Boston Scientific device because of the leads. Since you sense between the tip of the leads and the coil. If the coil is straddling on the tricuspid valve, then you increase considerably the risk of P-wave oversensing. Okay, so anytime you will implant Boston Scientific leads, you need to push it far inside the right ventricle. If you place it at the limit and quite basal with the coil on the tricuspid valve, then you increase considerably the risk of P-wave oversensing. Okay. At the end, I had a look to maybe 2,000 patients, and this is the only patient where I observed this problem. You see, so it's not so often, even in Boston Scientific devices. Okay.
Okay.
If I had a look for the last 3 to 4 years in this high number of patients, so it's not so frequent either. Okay. Any question?
No.
Okay. So it's a quite old one. What do you think here?
So we see there's AFib on the atrial channel, and there's oversensing of the atrial signal on the ventricular channel.
Yeah, clearly you see here. So this patient is dependent. You have to understand also something. When you are dependent, oversensing is a problem for 2 reasons. First, in Boston devices, it appears that you are much more sensitive after pacing than after sensing in the right ventricle. Okay?
Okay.
Understand that? Because of different parameters, we will not discuss too much about it, but it's the automatic gain control in Boston, and it's considered to be much more sensitive after pacing than after sensing. Therefore, that's why after pacing you increase the risk to oversense very small signals. Okay?
Yeah.
First of all. Second, if the patient is dependent, then you will not see one spontaneous real ventricular signal that will reset the level of sensitivity. You understand?
Yeah.
The problem here is that if you sense one small signal, then the device will work with very, very low sensitivity. The nominal value is 0.6 millivolts, and you will work all the time at 0.6 millivolts with a high risk of oversensing the next signals. Okay? If you're not dependent, at one time you will see one real ventricles that will reset the level of sensitivity, and therefore you will not sense the one after. You understand? That's why when you are dependent, that's a problem, because first you increase considerably the risk of oversensing. You increase considerably the probability of prolonged oversensing. And third, of course, if you're dependent, you increase the risk of asystole because of oversensing. Okay? You see the pause here? So the patient was symptomatic. It's not very long here. By chance, there is a diminution of the amplitude of the signals. Therefore, the patients did not have syncope, but at least a minimum of hypotonia in these patients. You understand?
Yeah.
Okay. So remember, if you want to illustrate the problem of P-wave oversensing, of atrial activity oversensing, most of the time it is with a Boston Scientific device because of the specificity of the lead, the pseudo-bipolar, integrated bipolar leads, and you increase the risk of atrial oversensing. In Boston devices, you are probably much more sensitive after pacing, after right ventricular pacing, than after right ventricular sensing. Therefore, in patients dependent, like here, there is an increased risk of oversensing of small signals, and of course, of prolonged oversensing of small signals, and therefore of symptoms. And sometimes in this patient, you will see prolonged oversensing, and at the end, a shock is delivered. Okay? So most of the time, the sequence is when you analyze the symptoms of patients. If the patients say, okay, I presented first with a syncope and then a shock was delivered, the first thing that you will think is that it is probably an appropriate shock. Syncope is caused by ventricular fibrillation, and then the shock is delivered. And what you see here is the only case where it's not exactly like that. It's not appropriate, but if you're completely dependent and there is oversensing, there is a risk that patient-dependent, oversensing, prolonged pause, no pacing, syncope, and then shock delivery. Okay? So the sequence syncope before the shock means it's an appropriate therapy. It's not true in this case. Okay?
Okay. Yeah.
Here? Good. What do you think here? So this is a triple chamber ICD.
Yeah. So at first A-sense, V-sense, and then we have fast cycles both on atrium and right ventricular channel. Could be oversensing.
Oversensing of what? See here,
External noise.
external noise. You think let's consider just this channel, the atrium. You would say it's external noise?
No.
What would you say?
Not sure, honestly. It could, at first, it could be a real
it could be atrial fibrillation. You agree?
Yeah.
Okay. If you look at this, that seems real. Huh? These are real signals. Does not look like. But now let's consider it's a single lead, single ICD with just a ventricular lead. What would you say here on this one?
Here, say that the lead, there's a problem with the lead. If it was just
when there is a problem of the lead, you see here the patient is spontaneous. Huh? So these are supposed to be the right ventricle signals. Okay?
Yeah.
Agree? Now, if you say this there is oversensing, you should still see the real ventricle signals. You understand?
Yeah.
If it is oversensing of something, I would expect to see exactly at the same timing the real ventricular signals, and that's not the case here. So, for example, if I did not have the atrial channel, I would say, okay, this is the ventricle, and then this looks like ventricular fibrillation. You agree with that?
Yeah.
Yeah, for me, it does not look like a problem of leads, but a problem of ventricular fibrillation. And here, a problem of atrial fibrillation. The problem is that you have exactly at the same time both of these arrhythmia. And if you look carefully here, you see that the timing is very close, right atrium and right ventricle. Okay.
Yep.
So at one time it's prolonged, and you see it's exactly at the same timing, and then at one time one shock is delivered because this is the end of the charge. And then what do you see?
Well, terminates both arrhythmia.
Okay, so what could be the possibility here? Have an idea?
No.
So the shock is efficient. You have the same timing atrial and right ventricle. In fact, that's the case of one displaced right ventricular lead inside the atrium. Okay, that's the case here. And that's why, okay, so there was the diagnosis in the chats, but yes, that's the dislodgement of the right ventricular lead inside the right atrium. Okay. And by the patient is not lucky, but at this time there is a real episode of atrial fibrillation. Okay, atrial fibrillations, and therefore oversensing, and then the shock is delivered, and at the end of the shock, no more atrial fibrillation, reduction of the arrhythmia, and then, okay, you understand?
Yeah.
So that was the case of early dislodgement the day after the implantations. Okay, the context, of course, is important also. Okay. What do you think here? Yes, that there is a question. I don't know if you see the chats, but would it be the same exactly if there was a dislodgement of the right atrial lead inside the right ventricle with a problem of ventricular fibrillation? That will be exactly the same aspect. And first of all, when I have seen this tracing, I did not know the clinical situation of the patients. I had reviewed all the tracing coming from Boston, so I have seen some tracing without any clue about the clinical situation of the patient. And in this case, when I've seen this tracing, I was thinking maybe it's a right atrial dislodgement inside the right ventricle, or the other way out, right ventricular lead dislodgement inside the right atrium in case of atrial fibrillation or ventricular fibrillation. And in this situation, it was a problem of dislodgement of the right ventricular lead. But I think that if it had been a dislodgement of the right atrial lead inside the right ventricle with ventricular fibrillation, the aspect will be exactly the same. Okay, what do you think here?
It's probably T-wave oversensing.
It is probably T-wave oversensing. Yes, you see here the signal and then the T-wave oversensing. I have shown you this tracing because this tracing is coming from the United States. In my all the patients I have ever seen in all my life in Boston Scientific ICD, I have never seen a single case of T-wave oversensing, not one. So this patient comes from United States, one tracing I could find somewhere, but in our centers. So just to say that it's very, 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 very infrequent in Boston Scientific devices. And that's surprising. Different reasons have been proposed to explain why there was no T-wave oversensing in patients implanted with Boston Scientific devices. The filters, of course, are very important. When you discuss with the different constructors, they give you a lot of information about a lot of things in their ICDs, but they never give a single information about how they filter their signals. And I think that Boston has found a solution not to encounter any kind of problem of T-wave oversensing. It's not just a question of filters, but I think that the filters are very important here. We could spend some time also to explain the way it senses. It's what is called the automatic gain control. It's very specific to Boston. But one of the things also is that there is no limitation in terms of R-wave sensing. It will sense up to 32 millivolts, and it will adapt the sensing profile up to a value of 32 millivolts. So it's quite, and this also may decrease the risk of seeing problem of T-wave oversensing. So once more, I show you this tracing, but just to say that it is so infrequent that you will probably never see any problem of T-wave oversensing in a patient with a Boston device. For sure, with an endovenous ICD, they have a lot of problem of T-wave oversensing with subcutaneous ICDs in Boston, but not with their traditional endovenous ICDs. Okay. Any question? No. So once more, if you have a look to any textbook about ICDs, you will see that most of the time P-wave oversensing is illustrated with the Boston Scientific devices, but it's never the case in case of T-wave oversensing. Most of the time it's going to be a Medtronic or Abbott device, or maybe Biotronic. In the old Biotronic devices, you could see also lots of T-wave oversensing, and this has considerably decreased in their new platforms in Biotronic. They have modified their sensing profile and their filters, and now you have considerably decreased the amount of T-wave oversensing. Okay, for R-wave double counting, so double counting of R-wave, most of the time in the old textbooks, it was a Biotronic also, because the blanking, the post-sensing blanking, was the shortest of all. It was 80 milliseconds in Biotronic. So you increase considerably the risk of R-wave double counting. And since it has been modified in the new platforms, now it's 110 milliseconds. The amount of double counting of the R-wave has also considerably decreased in the new Biotronic devices. Okay, any question? But that's important here. If you see a patient with high amounts of T-wave oversensing, I would highly recommend to implant a Boston devices. If you change the box, for example, because I think you will considerably decrease this risk. Okay.
I think you're right, Pierre. It's mostly about filters, though. I think on Twitter, I've seen some cases of T-wave oversensing in Medtronic devices which they have then performed a box change to Boston, and then the T wave suddenly disappears. Huh? So I put it in the chat. I don't know if you can see it, but it's two tracings. The first one is Medtronic with evident, and the second one is Boston, where the T wave is really small.
So I don't know, there were cases like that. That was my point of view, theoretical, but now it's become practical, you see, but it's really logical. It's surprising to see the amount of T-wave oversensing in Medtronic devices still, after pacing, for example. After sensing, the T-wave oversensing after sensing, so R-wave and then T-wave oversensing, it's not so important. But after pacing, you will see many of these cases. The same for about devices. And for example, in CRT device, that can be really a problem. And it's surprising to see that I can say you never see it with the bone sound scientific device. With microport also, the rate of T-wave oversensing is very low. Okay. After pacing, with Medtronic and Abbott, you see too many of this. I think this should be really corrected. I don't understand why it has not been corrected yet. So, for example, in Medtronic, you have the possibility to program a specific algorithm to diagnose the problem of T-wave sensing and inhibit the therapy, so decrease the amount of inappropriate therapy. But I think that there must be a reason why in Boston you don't see this kind of thing, and I think it would be a good idea if it could be corrected in the new Medtronic or Abbott devices. Okay. No question. This tracing here.
This is probably diaphragmatic myopotential.
Exactly. This is exactly the same. Probably myopotentials. So quite low amplitude signals, very fast, saturating the baseline, you see, and with some, evolution, small increase, and then decrease in the amplitudes. And this could be easily replicated during the consultation while the patient was performing Valsalva or eye breathing, see, and that was clearly a problem of diaphragmatic oversensing. So the problem of myopotential oversensing needs to be understood, okay? Basically, there are two kinds of myopotential that could be detected. The first one are pectoral myopotentials, and the second ones are diaphragmatic myopotentials. So if you see this kind of tracing, the patient will come to the consult, and then you will do the interrogation, and then you will try to replicate. So the first thing I do in this case is that I increase the sensitivity, decreasing the value. For example, if it's programmed at 0.6 millivolt, I will program 0.3 millivolt to increase as much as possible the possibility to diagnose the problem of the sensing. And then I will look for, I will do many things for pectoral myopotentials. So some maneuvers, specific maneuvers to try to replicate this. And the second thing, I will ask the patient to breathe lying or standing in different positions and deep breathing Valsalva. And then most of the time, if this is a problem of myopotential sensing, you will have the possibility to replicate and see which kind of oversensing. And then really, I'm always surprised by sometimes, not always, but sometimes some physician reaction about this. It's a bit surprising to me many times. So you need to understand that if it is an ICD and if you can replicate pectoral myopotential, then there is a dysfunction of the lead. It's simple. A bipolar lead cannot oversense myopotential, pectoral myopotential, if there is no problem at the level of the leads. So you see, sometimes the signals are very small, but if I see problem of oversensing of pectoral myopotential, I will not, as I see many times, I will not decrease the level of sensitivity and say, okay, you can go back home and then we'll see what happens. If you do this in many cases, it will end up with inappropriate shocks. Because at one time, if there is a problem on the lead, then it will increase. It will not, the problem will not improve. It will, most of the time, it will increase, and at the end, you will receive inappropriate shocks. So I don't think if you can replicate pectoral myopotential, there is a lead dysfunction, and then you need to change the lead. Of course, you need to consider the patient and see if he's very old or something like that, but you need to do something to avoid the shocks. And the solution is clearly not to modify the sensitivity. In case of oversensing of diaphragmatic myopotential, then the situation is different. Most of the time, it's a question of positioning of the lead. It's not a problem of lead dysfunction. The lead is sensing the signals because it has been positioned close to yes, and the same, the risk is increased in Boston Scientific devices because the risk is increased with pseudo-bipolar leads because of the distance between the tip of the lead and the coil. If if these two are quite horizontal, then you increase the risk of diaphragmatic oversensing. So the same in many books, textbooks, the problem of diaphragmatic myopotential is illustrated with the Boston Scientific device. The risk is increased clearly with this kind of leads. But in this situation, the lead is not dysfunctional. It senses something it should not sense. So then there you may consider the two solution is either you modify the position of the lead, but you require a new implantation, or you may consider decreasing the sensitivity, increasing the value, just to avoid this, because it does not traduce the fact that there is a lead dysfunction. Okay, so I don't know if it's very clear, but two quite a close situation, myopotential oversensing, but at the end, according to me, two very different situations, and you need really to consider one, change the lead, and the other one, try to see if you may find a solution. If you decrease the sensitivity in terms of diaphragmatic myopotential, then you increase the risk to undersense a real episode of ventricular fibrillation. So of course, it's a balance between the advantage and the inconvenience. I don't say you can decrease the level of sensitivity without any kind of problem, but at least that may seem logical. Anytime we see pectoral myopotential coming from other centers, we many times see that the physician has just decided to decrease the level of sensitivity. And that's completely, I think, illogical, not logical at all. Okay, any comments or any questions? No, Hugo Pierre, something?
No.
Marc? Nothing more?
No, very clear, thank you.
Okay, so next Monday is going to be the last one about Boston, and we're going to discuss about discrimination. And I think Boston is a good manufacturer to discuss about discrimination, because it's very clear to explain the way it works, and there are some advantages and also some inconveniences. So we're going to discuss next Monday about single lead discrimination and dual chamber discrimination. Okay. See you on Monday. Bye.